A 60-year-old man presents with severe watery diarrhea, massive abdominal distension, and marked leukocytosis. He was recently discharged after prolonged treatment for necrotizing fasciitis of the leg. I am showing you an abdominal radiograph and two coronal CT images. Describe the findings.
Okay, looking at the images, the abdominal radiograph demonstrates a diffusely dilated, gas-filled colon with marked nodular thickening of the transverse haustral folds, representing the classic thumbprinting sign. The coronal CT images confirm profound, diffuse, near-circumferential, low-attenuation wall thickening of the entire colon, reaching up to 2 centimeters in thickness.
What other supportive abdominal findings are present on the coronal CT images?
Well, there is diffuse, intensely bright mucosal hyperenhancement, prominent surrounding pericolonic inflammatory fat stranding, and a large volume of free intraperitoneal fluid, indicating a severe generalized inflammatory state.
Given the extreme degree of diffuse colonic edema following recent, prolonged broad-spectrum antibiotic therapy, what is the primary diagnosis?
The primary diagnosis is severe fulminant pseudomembranous colitis, a condition caused by the overgrowth and toxin production of Clostridioides difficile.
When viewing this massively edematous colon longitudinally on CT, what specific radiologic sign is often described?
This is known as the accordion sign.
What anatomical structures create the alternating bands of the accordion sign on the CT?
If we look closely, it is created by orally administered contrast material, or air, trapped between the massively thickened edematous transverse haustral folds, alternating with the severe, low attenuation submucosal edema, closely resembling the bellows of an accordion.
What two critical life-threatening complications of this specific disease must you assess for on every single slice of the scan?
So, I must meticulously evaluate for toxic megacolon, which is indicated by massive colonic distension greater than 6 centimeters with a complete loss of haustral markings. I must also search for pneumatosis intestinalis, or free intraperitoneal air, which would indicate irreversible ischemic necrosis and frank bowel perforation.
How do you distinguish this severe pancolitis from ischemic colitis on CT?
Ischemic colitis classically affects specific vascular watershed areas, such as the splenic flexure or rectosigmoid junction, rather than causing a diffuse pancolitis. Furthermore, true ischemia will demonstrate poor or completely absent mural enhancement, unlike the intense mucosal hyperenhancement seen here.
How would you manage this patient as a radiologist?
Based on that, this is a potentially lethal fulminant colitis. I would immediately place a critical results call to both the intensive care and general surgery teams to report the profound pancolitis and the large volume of ascites.
What specific warning would you give to the surgical team during that call?
Based on that, while the medical teams initiate targeted aggressive therapies, I would advise the surgical team to remain on extremely high alert. They must be prepared for an emergency subtotal colectomy if the patient's clinical status continues to deteriorate, or if signs of toxic megacolon or perforation develop.